Good morning, everyone, and welcome to the summit and welcome to our session on Arizona's Advanced Directive Registry. My name is Tony Fonzi. I'm the Chief Innovation Officer for Health Current. Before I introduce my panel members, I wanted to just say a couple of things. First of all, these three people have been my mentors as Health Current and I dive into the world of advanced care planning. And it is a large community out there of people who are very vested in this work, committed to it, and spending tremendous amounts of energy educating others and providing ability for people to both decide on their end of life issues and then to capture them in a document. I know I speak for every Health Current team member involved in this project when I say what an honor and a privilege it has been to get to know these people and to help participate in this work. Sorry. Okay, I got to get the hang of it. Obviously, moving the slides. All right. The first person I'd like to introduce to you is Sarah Asher. Sarah is the Associate Vice President for the Arizona End of Life Care Partnership, known as EOLCP, anchored within the United Way in Tucson in southern Arizona. EOLCP includes a passionate, engaged group of over 30 organizations who are committed, knowledgeable, and vested in making a difference in all aspects of end-of-life care. And I'm proud to say that Health Current is now a member of EOLCP. Our next panelist is Sandy Severson. Sandy serves as the Senior Vice President for Care Improvement for the Arizona Hospital and Healthcare Association, ASHA. Sandy combines her 40 years of nursing experience with her quite formidable management and leadership skills and background to lead two major ASHA initiatives, the Thoughtful Life Conversations and the Arizona Coalition to Transform Serious Illness Care. Sandy is also the state lead for POLST, Physician Orders for Life-Sustaining Treatment, and there is no stronger advocate for POLST than Sandy. Our third panelist is Steve Wagner. Steve is a City of Phoenix firefighter and paramedic, and he is also the president and CEO of the Right Care Foundation. Right Care advocates for best practice emergency care, and I love their mission. It's to save lives and honor wishes. Our ADR work group, which I'll speak to in a minute, has 5 representatives from Arizona fire departments and EMT organizations. They can all speak fervently from profound experience dealing on nearly a daily basis with what happens when the end-of-life experience goes right and what happens when it goes wrong. Steve's passionate and personal commitment to improving this experience is both admirable and fascinating, frankly, and I look forward to hearing what he has to say today. Our intent in this discussion is to introduce you to the ADR project and then allow the panelists to speak about how they envision the project interacting with and supporting the work that they're doing in their individual practices. We will have time, I think, for questions, but I'm going to ask you, you can go ahead and submit them. We're going to answer them at the end. If for some reason we don't have all the time we need to do that, we will get them answered and have the responses available. So this is an important slide for me. We're a technical company. And a lot of times what we do, we just kind of embed in the technology. And certainly there is technology involved in bringing up the Advanced Directive Registry. But that is not the mission of this project. Our mission is to comprehensively change the state's paradigm for creating, capturing, and retrieving ACP. And we want to do it by establishing and successfully promoting a trusted registry that becomes the primary source of documents and also the primary delivery system of documents to a native system where a provider can interact with them. So why Health Current? Why did this project end up with us? Well, it was a legislative decision, but there was, I think, sound logic behind it. One is over the almost 10 years we've been working with Arizona's healthcare providers, we have become a trusted, recognized, really a neutral, safe zone, even for companies that normally compete against each other, to identify how we can all advance healthcare and now end-of-life documentation and experience in the state. And the success of this registry is largely going to be driven by the acceptance of our healthcare community. So our relationship with the healthcare community, our experience together will all help this work the way it needs to. We have over 750 participating organizations. Many of them have interfaces. In fact, we've spent 10 years and millions of dollars building hundreds of interfaces that can be used to send information and documentation across the state. And that is going to be an essential provision of the registry as well. The other thing we have is we have 13 million unique individuals identified in our master person index. And that's another primary function in allowing the registry to work. And we are expert at allowing people to share data, but use it from within their own native systems. So if you use NextGen, Cerner, Epic, it's very possible, and what we will be working towards is allowing these documents to appear and be used in your native systems. So that is why Health Current. I think one of the things we did was probably one of the best things when we started this project was to build a work group. And we went out into the community and we identified and got help from over 30 different organizations from across the entire state. People who are engaged in this work. And frankly, I have to say, a year ago, I really had no clue how much energy and imagination and capability and intelligence was being dedicated to the work of helping people understand the importance of end-of-life care. And it's, as I said earlier, it's been a pleasure getting into this group and knowing these people, but they're a powerhouse and they are really driving this effort along with us. So let me tell you a little bit about what the ADR will do and how it works. As I said earlier, every person in there will have a unique identifier. So if you have documents in there and you want to update them, void them, replace them, you can do all of that and still it's all underneath that one single person identifier. We will handle all forms of advanced care planning documents, including durable healthcare and mental health care powers of attorney, and they can be combined as well. Living wills, pre-hospital medical care directives, DNRs, POLST, and the system will not prohibit the uploading of other forms of documentation. One of the things that's happening in this segment of the industry is there's a push to allow people to explain their end-of-life desires in multiple different types of forms, which could even at some point include voice. So I don't expect that to happen right away, but it's not prohibited in the design of our system. We anticipate having users from the community. We will allow individuals to create their own documents in the system, to upload documents. They can have proxies, legal representatives, all upload documents on their behalf, their healthcare providers. And we will also have a viewing capability. So for example, somebody like Steve is out on a run, they would have the ability to go into the system and look up someone's advanced care directives. The main way that ultimately we envision this working is that the registry actually does most of its work under the covers. Here's an example of how that might work. If we're exchanging documents with a health system whom we routinely work with, and a patient registers in their hospital or in their ED, we get notification of that. Well, we have the ability to get that notification, look and see if we have an advanced directive for that patient, and then forward that to the EHR without really anybody doing anything explicit at that point. And that would be really an optimal way of using the system. Another way we could do that is if a 911 call is actually able to identify the person the patient on the other end, they can give us that information. We could push an advance directive or a DNR out to the truck while it's en route. So our objective would to be make this as easy and fluid as possible. And of course, anybody can go into the portal the system has and go in and access the data that way. And the other thing the system's doing, this is important, it's not just technology and a registry. It's a library and a pointer to libraries of educational information, planning information, tutorials. So if you decided to go out there and create your own documentation, you would be able to leverage both existing documentation that's already out there and also documentation that we're building as part of the system. So here's the timeline. We spent really the first quarter of the year, maybe a little bit more, building the work group, getting our charter, and then we really dove into defining the requirements of the system. Where we are now is we had sent out an RFP. We received 5 responses, and we're in the process of narrowing those down. And within the next number of weeks, we will be seeing demos and coming up with a final decision. After that, what we will be doing is migrating documents from the existing Secretary of State registry into our system. And then we are in the process of defining several pilot implementations. So we think it'll be about mid next year when we're able to expand beyond that. And with that, I'd now like to invite Sarah to come forward and talk to us about her work at EOLCP.
Thank you so much, Tony. Good morning, everyone, or good afternoon if you're on the East Coast. I'd just like to take a few minutes to talk about the work of our partnership, why it's important, and why the work of Health Current and this Advanced Directives Registry is so important to our work. Our Arizona End-of-Life Care Partnership is a network of organizations and individuals based here in Tucson, Arizona, where we're trying to create a model community partnership with a shared mission to enhance the way we live by fundamentally changing the way we talk about death. Even though death is the one thing we all share in common, it is often very difficult to talk about. If anything has illuminated and accentuated the importance of our work now, it's COVID and this pandemic, bringing mortality to the forefront every single day, whether that's conscious or subconscious. Next slide. So we, the Arizona End-of-Life Care Partnership, are anchored at United Way of Tucson in Southern Arizona. And by that, I mean that our infrastructure is based at United Way. And our infrastructure team includes me, along with a data scientist, a grants management specialist, and an operations director. We are truly trying to merge the worlds of healthcare and community. I came into this role after 35 plus years in healthcare, predominantly in hospitals, and most recently leading patient experience departments for hospitals. And coming to the community-based side has been quite enlightening for me, and really has emphasized the need for us to start understanding each other's languages or creating common languages, because we in healthcare and in community speak very different languages. We need to break down silos in order to achieve our vision, which is to ensure that people receive the care they desire at the end of life. Next slide. Our partnership has grown significantly in the past 3 years from a small coalition of leaders, literally 10 people sitting around a table, and has grown to an organization of 14 grantees, 28 investing partner organizations, and 300 plus stakeholders. We started with a grant. There's a typo in this slide. The grant, initial grant was actually in 2017 for over $3 million across 10 organizations, thanks to the Lovell Foundation and Community Foundation for Southern Arizona, to really create this partnership and the backbone work for this partnership. This past July, we received another $3.6 million across organizations to continue our partnership work. I really encourage all of you to go to our website, azendoflifecare.org, for more details and information in the near future. Next slide. Our partnership work is really grounded on the foundation of 6 pillars around which we've organized 6 action teams. And those pillars and action teams include community outreach, community-based education, healthcare provider education, workforce development, workplace initiatives, and policy and advocacy. Each of those teams is a cross-sector team sitting around now virtual tables to work toward common objectives and outcomes, all related to end-of-life care in our community. Truly trying to create a model here in Tucson, Arizona. The wheel at the center of the slide represents the interconnections that are necessary in our community to achieve high quality end-of-life care. And the top 5 pieces of this pie are really glued together through this important work by Health Current to create this advanced directives registry. We need to unite our community around this mission to enhance the way we live by fundamentally changing the way we talk about death. And we need to have people start to ponder what's important, get more comfortable having these conversations, plan for end of life, document those wishes, and perhaps most importantly, choosing your person or proxy who can make decisions or vocalize your decisions if you're unable to speak for yourself. Along the bottom part of this wheel are the parts of the ecosystem of end-of-life care, which include healthcare, cultural and faith communities, underserved communities, people who have difficulty accessing education about different choices, and people who enter the system through their own grief and loss of loved ones. Next slide. We really have some opportunities now in the current context of healthcare and the pandemic. We are, again, trying to merge these worlds of healthcare and community and have a truly community-based team approach. We have big opportunities now around social determinants of health. Those have been emphasized over the past several years, and finally healthcare systems are starting to realize the importance of those social determinants and the importance of community-based organization work. Conversations around death are now being framed as global wellness initiatives for all people. We have several national and Arizona-based initiatives that are very important to this work, and Sandy and Steve will talk a little bit more about that in a few minutes. Obviously, COVID has forever changed the way we think about mortality. It has exposed death as the great equalizer for us in that it comes to each of us. It can come at any time, at any age, and unexpected. COVID has also illuminated the fact that dying and the way people die is not an equalizer, that we need to focus on EDI, equity, diversity, and inclusion. We need to co-create data within vulnerable communities and populations. And last but not least, next slide. Well, I think I'm missing a slide. So the last slide says that Health Current, there it is. Health Current, the Advanced Directives Registry is really the glue for our work. So our partnership is working very, very hard to normalize conversations, to empower and engage people in documenting these wishes, to engage, empower, and educate physicians and other healthcare providers in these conversations and in this documentation. However, that work is really moot if there is no way for people to document, truly upload those wishes in a safe and secure system. And it's moot if those wishes cannot be accessed by healthcare systems and healthcare providers and family members or loved ones. So this work is essential to our work, and we're really excited and passionate about it. We are so appreciative of the work that's been done. Tony has been an outstanding leader, and it's been an honor to work with all of you. With that, I will pass the baton on to Sandy Severson from the Arizona Hospital and Healthcare Association.
Wonderful. Thank you, Sarah. Really love hearing your passion about this important work. Tony, if you would just maybe clip through a number of the clicks so that the total slide would be there. My role at the Hospital Association is really to improve the health and the health care of the people in the communities across Arizona. And as a nurse, this really resonates. It's something I can get excited about. Our Thoughtful Life Conversation program began in late 2015 when the Hospital Association's board felt very strongly that they needed to do something to improve care for the seriously ill. They acknowledged that there was a lack of conversations with people about their diagnosis and their prognosis, and it resulted in crisis care that really didn't add any quality or more days, less suffering to the patient's longevity. It actually increased suffering, that crisis care showing up in the ED and being in the ICU just to be discharged. So that they felt very strongly that we needed to do something. And so we developed Thoughtful Life Conversations kind of as a means to increase those conversations about advanced care planning, wanting people to be better prepared, complete their advanced directives, and plan for the future, think about what their goals of care, to document them, and then only then we as healthcare providers could actually honor them. Can you see where the real issue is, though? If everyone completes their wonderful documents, but accessibility to them is an issue. So that's where we really believe our scope and our programs align with the people on this panel, with EMS, with other partners across the state, and with Health Current, because accessibility is really important. In the next slide, I'll just do a brief overview of a few of our programs, and not a whole lot of detail, but historically, I think we all thought when we began this work that the hospital was the center of the universe, with all of the post-acute care, the clinics, the long-term care, the home health, all of that as we're supporting partners. But we quickly realized that we had it all wrong. The patient and their family are at the center. And we really needed to plan from their perspective. What are their needs? We have to have more and better conversations with them about what their healthcare options and choices are. People die only once. They don't have any experience in this process. They depend on us to help them through this process. This difficult time. And bottom line is, we fail miserably at doing that, and we don't do it very well. So all of our programs here consist of healthcare providers, community volunteers, patients across the state who felt a tremendous need, a duty, a responsibility to really improve the tools, the processes, and the care processes and really the policies of how we actually pay providers. Because we have to change the way we provide care if we're going to be successful, if we want people to get the care that they want. So we did a deep dive and we really looked at what educational programs were available, and we were kind of shocked because we knew we could do it so much better. We developed evidence-based or adapted evidence-based professional education and how we communicate effectively. That communications in serious illness. We then went and realized we don't have POLST in Arizona. Many of us that worked in many states, other states other than Arizona, POLST has been around for many, many years. So we really needed to make sure that our work was across the state, not only doing education, but of hospitals, but of all healthcare providers. We did community education on advanced care planning and learned early on that there were a lot of barriers, that the forms were very, very difficult. So we developed a short form, a one-page living will and a one-page healthcare power of attorney with mental health authority. And then for the elderly and the frail, or those that have visual acuity issues, large print fourth grade reading level documents, and I thought that was really important. We developed a POLST program, a bunch of volunteers who said, I want to do this. This is really important to our work. The Arizona Coalition to Transform Seriously Ill Care came out of that we needed data and revised processes and policies to change the way we provide care. So we're working to develop new care models to support more days at home because, people don't want to die in the hospital. They really want to be at home at the end of their lives. We're in the process right now of rolling out a STEP program, a statewide enhancement palliative care program that's for COVID patients. That's via telehealth. And so our focus is the underserved populations, the ones that don't have access to palliative care and telehealth. And then we also were a recipient of the Level Foundation and received $1 million back in 2017 to do this work over 4 years, and are part of the Arizona End of Life Care Partnership working with others. On the next slide, we talk a little bit about the advanced care planning process, and you can just click through these. It's a process that rolls out over a lifetime. You can really see that when you're young and you're healthy, you do a living will, and you have a proxy or an agent that makes decisions for you when you can't. But once you become seriously ill, everything changes. And we didn't have a good process for that. And that's why we developed the POLST program in Arizona and are working with National POLST. We're now in an endorsed state. But I do think that when we're young and we're healthy, we think we're going to live forever. We think the sky's the limit. More than 2/3 of the time, we don't have a living will or a healthcare power of attorney because we fail to plan for the future. But as we grow older, as our horizons contract, when you see that you've got a finite number of days and your future is uncertain, now you focus more on what's important today. What are those everyday pleasures? And so we know that people with priorities with serious illness have other priorities than living longer. And that's what POLST is about, is making sure that we ask them what those priorities are. In the next slide, we actually talk about what are our fundamentals of POLST and just kind of a high-level overview. POLST, unfortunately, Tony, it's changed. It's no longer an acronym. We're part of National POLST, and so it's a process. It's a portable medical order, but it starts with a conversation about the goals of care, making sure that people understand their prognosis, their diagnosis, and then what's important to them. And from there, then they work together and make some shared decision making about what future treatment plans that they want. This is that portable medical order that's portable across all care settings. And it's only used, again, with those people that are seriously ill and frail the last 1 to 2 years of life, and always portable. And the next slide is just a brief summary of some key concept of POLST, that it's always voluntary. It starts with a discussion. It's shared decision making with the provider on what will work, what won't work for you. It's a medical order, so it's signed by a physician and the patient. It is not a healthcare directive, but it's healthcare directive or your living will should be aligned with it, and then it must be shared wisely. And then in the next slide are just some additional resources. We're dedicated to the belief that all people should experience end of life in a way that matches their values and their goals. We work to provide more good days than bad days. If you want to go fast, go alone. If you want to go far, go together. We stand with partners across the state, Health Current and Sarah and Steve, and many others we're proud partners to support the Advanced Directive Registry. It will make a difference in people's lives so they can live well and end well. Thank you. And Steve, I'm going to pass it off to you.
Great. And thank you, Sandy and Sarah. I wholeheartedly agree with everything you just said. And I have to say that I am honored to be here to discuss something that has been so passionate for me and our organization for literally a decade. Good morning and afternoon, everybody. My name is Steve Wagner. I'm president and founder of the Right Care Foundation. We are an Arizona nonprofit and 501c3, and our purpose is to advocate for best practice care. Most importantly, best practice care before the fire truck arrives. And this includes information being available to first responders, such as the DNR form or POLST forms or advanced directive forms. I can say this, as Tony mentioned, because I'm actually an active duty firefighter paramedic. So my heart's going to come out a little bit here in this discussion, because all too frequently I have arrived on the scene. Next slide, please. On a fire truck at an emergency where somebody has lost pulse and is not breathing and has had an advanced directive. And the only way that I can honor that advanced directive is if it is presented to me immediately upon my arrival or our arrival. And I not only speak for myself, but I speak for firefighters across the country, first responders and paramedics across the country, that it is supremely frustrating for us every time that we resuscitate someone unwittingly against their will because information is not available to us. So let's go ahead and go to the next slide. So our default, first responders' default, is to save lives. We equally respect our patients' right to survival, as well as our patients' right to end-of-life wishes. As I mentioned earlier, we can only honor wishes when that information is made available to us. So I just want to, this slide here, talk a little bit about the importance of the immediacy of our action. So when we arrive on a scene, the most important thing we can do in the CPR or cardio pulmonary resuscitation process is to keep the brain alive. Well, we will always default without that information to immediately perfuse the brain. Next slide, please. So this slide is a bit clinical, but it describes and exemplifies the importance of feeding the brain with oxygen, and we have to do it immediately, and any interruption in that process causes brain cell death. Next slide, please. So while we're talking about survival, this is what survival looks like. This is somebody who survives to return to normal living. This is somebody who I personally was involved in his resuscitation, and he survived neurologically intact, and that could only happen with the immediate and essential resuscitation that took place for him to be able to return to normal living. He didn't have an advance directive. Next slide, please. So let's talk about folks that do have advance directives. Let's talk about the importance of making sure that that information is available to us. One thing I'd like to point out is when somebody calls 911, whether that's at a residence or at a long-term care facility, the firefighters that arrive on the scene, the paramedics that arrive on the scene are the ones who are making the decision whether to resuscitate or not. I think that's the missing piece for most folks, to understand that although EMRs and EHRs and EPCR systems have information in them, without the Advanced Directive Registry and the HIE, firefighters, the ones who are making the decision whether to resuscitate or not, have to have that information. If we don't have it, then we're going to resuscitate. I can tell you that I speak for all firefighters, literally in the country, that it is horrible for us to know that after the fact, when we receive pulses back on a patient, and we've done horrible things to somebody to enable them to regain their pulses, that they never wanted those pulses. It's horrible for us to know that we risked community, driving through intersections with lights and sirens, and doing everything we can, everything within our training and our ability to keep somebody alive, only to find out at the hospital that they never wanted to even be resuscitated. So I really just want to impress upon you the importance of this, of the HIE and of the Advanced Directive Registry, because without that, this is what survival looks like. Back up one slide or two slides, please. One more slide. This is the only, whoop. Thank you, Tony, I appreciate it. Sorry, I'm putting you through your paces. This is the only kind of survival that I think any of us would want. Advance two slides, please. And unfortunately, this is survival if we don't have the information that we need before we arrive on the scene. Now, that sounds horrible. And I don't want to speak only about horrible things. I really would like to talk about the exciting news. And that is that the HIE, the Health Current HIE and HIEs across the country have and integrate into patient care record keeping technologies that are available for firefighters, so that we have the ability, as Tony had mentioned, to have this information prior to our arrival. So we will never, hopefully in the future, see not survival, right? Or that kind of survival with pulses, which is the very reason why folks have a DNR, by the way, right? They wanted to avoid all of that. I am excited to be just a small part of this, and to promote the fact that if we have the information that we need, we can honor folks' wishes. And I want to mention just briefly, and I apologize if I'm over time, but the Advanced Directive Registry in the state of Arizona was created by statute in 2004. And the fact of the matter is that not one single first responder in the state of Arizona has had access to a single individual's DNR at time of need ever until now. So congratulations to all of us, to all Arizonans, because Health Current exists and the Advanced Directive Registry will exist to keep us from ever having to resuscitate people against their will again. Thank you. And Tony, back to you. I'd be happy to continue this conversation, answer any questions anybody has.
Well, thank you, Steve. And I want to thank all the panelists. You guys always inspire me, and I always learn something, and I did today as well. Thank you. We did have a couple of questions, and then I actually had, if we have time, a couple of questions that I'd like to ask my friends. One quick question here. Are you the Tony Fonzie who used to be at SunQuest? Yes. I'll insert another question. Are you the Tony Fonzie who can't advance a slide worth a damn? Yes. Another question, this is actually a great question. Regarding advanced directives, will an HIE user be able to access this information for someone who has opted out of medical and Part 2 data? That is a really good question. I've not thought of that before. The way that the HIE works with regards to opting out is we still get the data into the HIE, we just don't share it. So technically, and I think actually legally, we would be able to still share the advanced directive even if somebody opted out. Part 2 data is its own thing, so that's really not, I think, part of this conversation. But I believe that we would still be able to share the directives if somebody was one of the relatively small number of people who opted out. I think we have like 2 or 3 minutes left, and I actually had a couple of questions I wanted to ask my friends again. Steve, you know, you can speak very well about the unfortunate human condition that happens when we resuscitate somebody who didn't want to be resuscitated. Do you have any data about how much that costs?
Well, I would just cite articles with regard to long-term care expense for vented patients, patients on acute long-term care. And I know that based on an article in the Arizona Republic, that one individual bears the cost or has borne the cost of $386,000 per year of sustaining life. Now, that would be not to mention the expense to public safety response, the advanced life support en route to the hospital, and then the hospital stabilization, et cetera. But that's just my perspective. I would defer to Sandy on this one because I think she would have much better data.
Do you, Sandy?
I hope.
You know, I don't look at it as dollars. I look at it as human suffering. And certainly we can research, and there's lots of articles published, but just think of the pain and the suffering with the person and the family, and actually all of the healthcare providers, as Steve talked about, not only for the EMS, but all of the other healthcare providers caring for that person. What we all want is the right care at the right time. And I think this registry will help us do that better. And so we're very excited about that.
Well, I think that's very true. So we only have a few seconds, but Sarah, did you want to say something or no? You're okay?
I'm okay. I just want to add that I think the most important thing we can do right away is increase awareness and education about the importance of advanced directives and the existence of the registry. And I think the Health Current upcoming education campaign for all of the people in all of our communities is going to be essential.
I agree, but thank you. So I just have one closing statement. As we can tell from everybody speaking today, solving the problems associated with recognizing and honoring end-of-life wishes is multifaceted and complicated. You have to help inform and educate people about the importance of creating the documents. Then you have to create the documents. Then you have to have them available in a safe and secure place. Then you have to take them where they're needed, when they're needed. We have to work with our physicians to be more comfortable dealing with end of life according to a patient's wishes. So this work it's never going to be a perfect time to do this work. It's never going to be simple. But I think the learnings from our work group and this team of people here is, I don't think there's a better time to engage in this work. So thank you all very much. Thank you, attendees in the summit. We appreciate your time. Have a good rest.